This briefing details the requirement for the structural integration of physical medicine and rehabilitation, or PM&R, into the Nepalese national health system. Historically, medical success in Nepal has been defined by acute survival, keeping a patient alive through surgery or medication. However, survival is the beginning of the process, not the end. A healthcare system fulfills its mandate when a patient successfully returns to their job, their school, and their family responsibilities. Physical medicine and rehabilitation, widely known as PM&R, is the specific medical specialty dedicated entirely to restoring this vital functional capability for patients. A system that finances acute trauma care but neglects functional restoration carries a hidden cost. It leaves families and the state to manage the lifelong economic burden of avoidable dependency. The demand for rehabilitation in Nepal is rising alongside our urbanization. We are seeing a high volume of disabling conditions resulting from road traffic accidents, strokes, and spinal cord injuries. Today, improvements in emergency medicine and surgical intervention mean more of these patients are surviving their initial life-threatening trauma. Consequently, our wards are now managing a high volume of post-acute survivors. While survival rates are climbing, the lack of structured rehabilitation means these survivors are often left permanently dependent on caregivers for their daily needs. Without an integrated PM&R system, these clinical successes create a growing population of citizens who are unable to participate in the economy, triggering a long-term social crisis. PM&R is a multidisciplinary team of therapists and social workers led by an MD physiatrist. Nepal often confuses them with physiotherapists, requiring separate policy. The physiatrist diagnoses and directs the overall plan. The physiotherapist is the allied professional executing that plan. To build a functional rehab infrastructure, the government must establish separate administrative quotas, or darbandi, specifically for MD physiatrists to lead these departments. Current legislative momentum supports this change. The Public Health Service Regulations of 2077 already recognize PM&R as a specialized service, and the 2083 Policy Roadmap proposes a dedicated National Rehabilitation Center. These policies require a concrete structural framework. Without dedicated personnel and quotas, these facilities will lack the clinical leadership necessary to operate. 3 actions are required immediately: establish MD physiatrist quotas, expand domestic academic training, and mandate the opening of specialized rehabilitation centers in every province. PM&R converts medical survival into a return to community life. Formalizing this specialty provides a clear path for patients to rejoin the workforce and resume their roles in Nepalese society.